To share with you my experience is on about remote interventions for pediatric patients with acquired brain injury. I work in a scientific institute, and my institute has been dedicated since 1985 to research, treatment, and training in the field of neurological and neuropsychological pathologies of developmental age. I work in a pediatric acquired brain injury unit, and we take care of children and adolescents with a traumatic brain injury, encephalitis, vascular disease, and brain tumor. We follow the patients from the acute phase until they return home. My institute is located in the north of Italy, very close to Lecco, and we are a high specialization unit, so we receive children from a lot of parts of Italy, and also from the south of Italy. And we sometimes these children come from far away from the institute, and when we discharge them, we discharge them in place far away from the institute as well. What about brain injury sequelae? In the acquired brain injury, we have several sequelae, and we have problems with cognitive function and everyday function, problems with the communication skills, behavior, and difficulty in school achievement, social abilities, and vocational aspects. So rehabilitation for pediatric ABA should be early, intensive, multidisciplinary, targeted to a focus, sustained in the time, and obviously evidence-based. So about the cognitive impairment, we can see that cognitive deficits are among the most disabling long-term consequences of acquired brain injury. And cognitive rehabilitation may limit long-term cognitive decay in these pathologies, and its negative impact on quality of life. Here you can see a feature in which there is the black line is typical cognitive development, and when you have a brain injury, you have a loss of cognitive function, like this. I don't know how. Anyway, and then you can have an improvement of cognitive function is a normal recovery, and then you can have a good natural recovery to reach almost the typical cognitive development, but you can also have a poor recovery. The dashed line with the black point means the intervention of rehabilitation. So you can improve cognitive function with cognitive rehabilitation in these patients. Telerehabilitation is very important for us. Traditional rehabilitation interventions, in fact, tend to be time-limited, costly, and not accessible to all the patients due to the distance from care centers also in Italy. And it does not guarantee treatment homogeneity across clinicians. So telerehabilitation allows care continuities, limits time and economic demands to families and institutes as compared to traditional rehabilitation. Moreover, telerehabilitation allows precise monitoring of interventions through the tracking potentialities that are ensured by technological devices. Aim of our study. We examined the feasibility and the efficacy of a home-based computerized cognitive training in a sample of Italian adolescents aged from 11 to 16 years old with a diagnosis of acquired brain injury. What about the step one, the feasibility study? The investigation of the feasibility is important to verify whether this type of intervention is appropriate in these pathologies if the research methodology needs any modifications, if a remote cognitive training could acceptable and sustainable for individuals, and the protocol that we use to test this aspect could be valid. Then we can go to the step 2, this efficacy studies. Sorry, maybe there is one. Yes. We selected a specific training, Lumosity Cognitive Training, that is a web-based platform providing different games aimed at stimulating different cognitive domains. And we choose to stimulate this domain: flexibility, memory, speed of proceeds, attention, and problem solving. And here you can see the game that we propose with this website platform. We choose training, this type of training, Lumosity, after to test a lot of training that you can find on the web. And we choose this one for this motive, but also because of the graphic, because we are working with the children that are useful to play with the games with a very, very great graphic. So if we propose a very simple game, children say, no, it's too old for us, and they don't play. So, and they don't perform the training. So we selected Lumosity also because it has adaptive, modifying the complexity of the games based on the individual performance. It consented an intensive daily training, but of a limited duration, saving patients from excessive cognitive requests. And difficulty of exercises progressively increased based on an automatic algorithm to the program, so that patients were required to gradually improve their competence. Here I show you our study Flowchart. We used a stepped wedge research design. So we enrolled our patients in 2 groups, and one group received Lumosity training at the beginning, and the other group no. And then we had a cross of the 2 groups. And we perform also a test up to 6 months. After 6 months, the finish of the training. Our patient performed 40 sessions at home, 20 minutes of training, once for working day for 8 weeks. And a weekly telephone-based contact with the participants and their parents was provided by a research team member in order to sustaining training adherence and record the reasons of any eventual dropouts. We enrolled 32 Italian adolescents with a diagnosis of acquired brain injury. And here you can see that we enrolled the patient without performing a selection based on the IQ level, because in our population we have a very lot of heterogeneity of IQ level. We published this feasibility study on +1 this year. To test the feasibility, we use 9 criteria taken from a previous study published in 2017, and is a study on a remote computer cognitive program for TBI. Here you can see that you have 4 measures for disability of intervention and 5 measures for the feasibility of study design and procedures. And all 9 feasibility criteria were met in our study, indicating the success of the training. The 97% of the participants completed it. Only 1 patient dropped out at the middle of the training due to the lack of interest in carrying out. And we perform also a questionnaire in which we ask them if they appreciate this training, and 90% of the participants say that it's a good training and showing neutral to positive global mean scores. What about efficacy? We conduct a study, the first study on non-progressive acquired brain injury patients because we decided to don't include tumor brain for the very particular patients, because they are very particular, because there is a progressive problem due to the tumor. So we enrolled our patients in these two groups that are balanced. And here you can see the cognitive functioning we tested. We tested full IQ and visual spatial working memory, executive function, problem solving, and we test also the academic skills in order to understand the possibility to generalize this cognitive stimulation. The comparison between the two enrolled groups show the efficacy of training only on visual spatial working memory for us. That was our primary outcome. And patients exhibited a better performance after the training than after the waiting list period. And maybe the improvement in visual spatial memory could be due to the fact that the visual spatial processes were more consistently stimulating across the exercises. All the exercises we propose have a visual spatial memory stimulation. So we think we can say that the improvement of cognitive skills depends on the intensity of the stimulation. In conclusions, we can say that cognitive training programs may be successfully proposed to pediatric brain-acquired patients, and also to those having low intellectual scores. And patients seem to appreciate the kind of programs and recognize they're useful. Improvement in visual spatial working memory from a game-like training are to be expected in patients with this type of situation of pathologies. Ongoing cash issues. There is a bias. A selection bias is associated with the enrollment of patients who spontaneously agreed to partake in the study. And the future research is required to verify the effects of cognitive training programs in a specific population in children, based on etiology, age, range, and intellectual competence. And training effects on more global cognitive abilities, such as academic skills, still need to be confirmed. I would like to spend a few words just to say that we are very excited about this new type of rehabilitation, and we are perform 3 cognitive training on brain tumor, congenital brain damage, and also a specific training on executive function in epilepsy, in patients with epilepsy. And we have a collaboration with Dr. Sherry Wade, that is working in Children's Hospital in Cincinnati. She performed an online family problem-solving training, and that she tested a lot. And so we translate this program and in Italian, and in this program there are also some videos, and we change the actors at the videos because it was very American, and we have to propose an Italian situation, and we have opened this network with the USA, and this program is tested also in England and in Australia. So we'll see what happens. Thank you very much.
Thank you very much for your presentation. We have no time for questions, but only for one short question. Any question? No?
Sorry.
How big was the change in visual spatial processing? Was it a clinically important one?
Yes, it was a clinically important, but only you can see only an improve in test and not in generalization. So the test is good, but the skills, the academic skills, for example, in which you can use this type of competence didn't change. So that's a problem of this training, the generalization. So maybe I think that you have to add other stimulation in which working memory or the other competences should be improved in exercise very close to the daily life.